for those of you who attended the last one, we discussed about ventricular anatomy. And we'll take one step further from there and let's do some soul searching in the brain. So the green structure, what you see here in deeply seated inside the brain, that's the pineal gland. And the one on your right side is a zoomed out view of the pineal gland. So it's basically a pea-sized gland, which is located in a very deep location, and it's adjacent to the brainstem and the thalamus. It is actually posterior to the third ventricle. And this is a zoomed out view on the right side where you can see the pink color is the pineal gland, and it's connected by two laminae. The stalk is basically composed of two laminae, the superior lamina, which you can see here, and the inferior lamina, which you can see here. These are called as the habenular commissure and the posterior commissure mainly. And this cavity here, that's the third ventricle, okay? And this small recess, which is projecting into the, towards the pineal gland, it's called as the pineal recess. And this structure here is a midline structure, and it is the splenium of the corpus callosum. So remember, last time we discussed about the corpus callosum being the superior boundary of the third ventricles, and of the lateral ventricle, and we discussed the third ventricle as well, the boundaries of the third ventricle. So this forms, this lies at the posterior boundary of the third ventricle. Okay, let me show you another view. So this is a top-down view of the brain. And here you can see this small slit-shaped structure. That's your third ventricle. And these are the lateral ventricle here. And the corpus callosum is obviously cut away to give you this view. And these two structures, like the small eggs on each side, they are the thalamus. So, and these four bodies, they are basically the colliculi. They form the posterior boundary of the cerebral aqueduct. Remember, we discussed the last time. So these are the colliculi. We call them the superior colliculi and the inferior colliculi. Or together they are known as the quadrigeminal bodies because they are four. So they sort of helps to regulate the eye movements and the auditory pathway. So to summarize, the pineal gland is basically sort of situated in a very important location. So any approach to the pineal gland, one has to consider all of these things when we are approaching to the pineal gland to even maybe take a biopsy or while attempting surgical resections. So the main aim of this presentation, the rundown is basically, I'll take you through anatomy and discuss what pineal gland does and what it's composed of. Then we're going to discuss various tumors of the pineal gland. And at the end, I'm going to discuss these operative approaches to the pineal gland. So after the location, the pineal gland is basically supplied by branches, the choroidal branches from the posterior cerebral artery. And it is also surrounded by a lot of important veins, which I'll come to later when I show you the operative approaches. When we take a histopathological section and examine with the H&E stain, this is what most of the pathologists do. And this is a normal structure, what you can see on a histopathological examination of a pineal gland. It looks more grainy with the pink and the dark blue cells. So various cells, what you can see in the pineal gland are the pinealocytes, which is the basic and main component of the gland. And it is the secretory cell of the gland which secretes the melatonin, and that's the sleep hormone. So the way it is secreted is when you open up your eyes in the daytime, there are light receptive cells in the retina, which sends a signal to two of the nuclei, mainly the suprachiasmatic nuclei and the paraventricular nuclei in the hypothalamus, which in turn sends a signal to the pineal gland, and then these cells, they produce the melatonin in the absence of sunlight. And when the sun comes up and when you wake up, that's when it sends signal to tell the pineal gland to basically stop producing melatonin so that you're awake. So I want all of you awake, okay? The second important cells are the neuroglial cells, which you can see here. These are the surrounding sort of cells which has supporting function, but there are different types of tumors, which we're going to discuss at the later stage, that can arise from any of these cells. And the interstitial cells are obviously the surrounding cells in between these pinealocytes. And when there are these small blood vessels which supply the pineal gland. So anything, there are these phagocytes which basically surround the blood vessels. So it's called perivascular phagocytes. And sometimes you can see normal calcification within the gland, which is known as corpora arenacea. And the fancy name is, that's a fancy name. It's also known as the brain sand. All right, so any guesses on this guy? Let me give you a hint. He also devised the Cartesian system. And his name is René Descartes. He was a French scientist who basically proposed, like he was really interested in Cartesian system, and he thought that the geometric center of the brain is the pineal gland. And he also proposed that it is seat of the soul. So you'll find tons of literature regarding the pineal gland. And among like most of the mythologies, like the Hindu mythology, you know about Lord Shiva's third eye, and in other mythologies as well, they used to consider pineal gland as the seat or the center of rational thoughts. And there's tons of literature you can find regarding awakening of the pineal gland, that's basically to help improve your personality. I don't know how much of that is true scientifically, but that was the reason I told you, let's do some soul searching. All right, so let's come to some scientific things. Tumors of pineal gland, they can arise from, like I said before, from any of those cells. And so basically we get to see a diverse group of tumors, and which have been divided histopathologically. The table on your right side, you can see they can be pineal parenchymal tumor, which can be pineocytoma, pineoblastoma, or pineal parenchymal tumor of intermediate grade. Or they can arise from one of those interstitial cells, like the neuroglial cell. They can lead to gliomas like astrocytoma, or like different grades of gliomas, basically. It can lead to oligodendroglioma or even glioblastoma, which is grade 4. And there are these important to mention here is the germ cell tumors, which can occur in the pineal gland. And they can be germinoma, embryonal carcinoma, yolk sac tumor, teratomas, and choriocarcinoma. And also, most important, you can see here these two, meningioma. So even though the pineal gland is covered by only pia mater, but why do you see meningiomas there? Because meningiomas, they basically arise from arachnoid cap cells, and sometimes you have ectopic rests of arachnoid cap cells in the pineal gland itself, and that can lead to these meningiomas. And metastatic tumors obviously can arise from anywhere and get deposited to the pineal gland. So three most common types of tumors in the pineal gland basically are the germ cell tumors, the pineal parenchymal tumors, and the gliomas. Overall, they form about less than 1% of tumors in adults, and more commonly seen in the children, about 3 to 8%. So basically, the clinical presentation, as you can obviously imagine, because of the location itself, like we discussed the last time as well, the location is so much critical here that it can block the CSF pathway and lead to elevated intracranial pressure due to obstructive hydrocephalus. And obviously, the features are non-specific, which are progressive headache, nausea and vomiting, and lethargy. But sometimes, as I said before, there's a quadrigeminal plate which controls the superior colliculi controls the vision. So that's basically the supranuclear control. What you may get here is we call as a Parinod syndrome, and it consists of different components or a few clinical symptoms like impaired upward gaze. The patient would not be able to look up when you ask them to. And there'll be lid retraction, and also the lid retraction here is also known as Collier sign. And there'll be dissociation between the near reflex and the light reflex when you check for those reflexes in the eye, and there'll be convergence nystagmus. So these together, these constellations, you may or may not see all of them, but spinal tumors, they do present with Parinod syndrome. And rarely they may develop, these tumors may develop hemorrhage inside, which is known as apoplexy. So important thing here, as opposed to tumors as opposed to the gliomas, is the medical history and the neurological examination is obviously important, but the germ cell tumor in pineal gland are really important because they are common. And there are these germ cell tumor markers. So if you see them, if you are able to identify these markers, then you don't need a surgery. You can practically avoid getting into brain, even for a biopsy. They can obviate the need for a biopsy or a surgical excision. So only thing you would require is if you are able to see these various germ cell markers, either in the serum or the CSF assay. These germ cell markers, they are also particular about, they can indicate subtype of the germ cell tumor, and only thing, if you are able to identify them, is you can give them radiation. So these are alpha-fetoprotein, which are commonly seen in the yolk sac tumor, but can be seen in the embryonal cell carcinoma and occasionally in the teratomas as well. Then beta-HCG most likely suggests choriocarcinoma, but can happen in germinoma with germinomas which have the syncytial trophoblastic cells, because those are the cells which secrete this hormone. And like I said, positive germ cell markers, they are pathognomonic. You do not need a tissue diagnosis. So, but you will require a radiological evaluation. That's basically to assess the degree of the hydrocephalus, because that's like if a patient develops hydrocephalus, you need to intervene no matter what, no matter what's the histology, you need to intervene. That becomes an emergency, and you need to decompress the ventricle that time. And that's where the importance of anatomy lies. So histological diagnosis is of paramount importance here, because of this reason that you can totally avoid surgery in one type of tumors while you have to do surgical excision in the other type of tumors. Let's come to these lesions one by one. First is the pineal cyst. They are non-neoplastic, so they're not tumor cysts, and they occur in the parenchyma. They have been found in about 25 to 40% of the autopsies, and MRI incidence is about 1.5 to 4.3%. Um, the reason for these is because a vast majority of these are asymptomatic. Like they can be there, but they may remain totally asymptomatic. And they're usually seen in younger patient age group with a slight female preponderance. So pineal cysts, benign lesions, majorly asymptomatic, seen in young patients, okay? Next, let's go to the pineal parenchymal tumors. Like I said before, uh, they are about 0.5% of all intracranial neoplasms. And basically, they can be of 3 different grades. They can be pineocytomas, or which is benign, or to the very extent, very end is the pineoblastoma, which is grade 4, and something in between, which is of intermediate differentiation. So this PPTID, the pineal parenchymal tumors of intermediate differentiations, they are newly added to the classification because we were the pathologists, they were able to find these of potential malignant, they have malignant potential as well. So important thing to remember here is the pineocytoma, they are histologically benign, they are non-invasive, and they do not see through the CSF. That's really important to know. So they do not see through the CSF, while the pineoblastomas, they can see through the CSF. So if you have a diagnosis, histopathological diagnosis of pineoblastoma, you need to look at the spinal cord as well, because you can have CSF deposits lower down in the lumbar spine. Next is the germ cell tumors. They are the most common neoplasms in the pineal region. All of them are malignant except for the mature teratomas. And the most common among them is the germinomas, which form about 41%. And teratomas comes the next, which can be mature, immature, or they might have malignant transformation. Yolk sac tumor, embryonal carcinoma, and choriocarcinoma. Important thing to remember here is that you can totally avoid a surgery. You need CSF markers or serum markers for the tumor proteins, which we mentioned earlier, and 80% of them, they arise near the third ventricle. And these tumors, they usually have a male predominance. So because we have different pathologies, that's why we need a treatment and a diagnostic algorithm on these tumors. So when a patient presents to you with that constellation of symptoms, like raised ICP, or if you see a Pineal syndrome, then you order an MRI. If you see a pineal lesion, then you look for whether the patient has a symptomatic hydrocephalus, or or like let's just follow this flow diagram here. So if the patient presents with raised ICP with hydrocephalus, then you have to do CSF diversion. You can do ETV, or you can do shunt. So basically, there are various thoughts nowadays that you try to avoid 2 different procedure on the same patient when you can do 2 different things on the same procedure. What I mean to say is when you attempt a ETV means endoscopic third ventriculostomy, which basically is you drill a small hole in the skull, and you open up the floor of the third ventricle. Let's go back to the anatomy. Let me explain you in a better way here. So we go from here and we go down through the foramen of Monroe, reach the third ventricle, and we open up the floor here. These are the mammillary bodies. Go from here down, mammillary bodies and liqueous membrane, we open here. Okay, that's the prepontine cistern. And so we basically decompress, we provide another pathway. So if the CSF is blocked at the cerebral aqueduct because of the compression by the pineal tumor, then you can open up an alternate pathway here via ETV. And at the same time, with your endoscope in, you can actually take biopsies here. So like I said, one procedure, two different things you can do at the same time. So that's when symptomatic patients, we do ETVs. If the patient is not symptomatic, you do CSF markers and the serum germ cell markers. If they turn out to be positive, then we can give various chemotherapies or radiotherapy. And most of the germinomas, they respond beautifully to these. And all you see is on a follow-up scan, the tumor is just disappears with that. So follow-up scan is really important in these tumors because sometimes you might see a residual tumor on follow-up. And that's when you think, because the response to chemoradiation is so great that if you see a residual, then you doubt your diagnosis in retrospect. Because we know from various studies that germinomas, they literally melt away with chemoradiation. So if you see a residual, that means that you have to suspect your diagnosis. There can be other tumors as well. There can be mixed pathologies. There can be, so that calls for a basically for a biopsy sometimes. So what you can see here, if the patient may be taken up for a biopsy at that point of time to basically look for, we call it a second look approach. So that's when you can do endoscopic or stereotactic biopsy to basically establish a histopathological diagnosis at that time. So in a surgical candidate, we have two options. We either go open surgical resection of the tumor in case it is malignant, or we go for stereotactic biopsies if we think that it is a benign tumor. Then open resection, we have multiple approaches, which we're going to discuss. And stereotactic biopsy or endoscopic biopsy is going to help us with the basically finding a diagnosis. And if we see that a tumor is malignant on a biopsy, then again, we come back, we add on the chemo and the radiation to that. So the treatment of these tumors basically divided into management of the hydrocephalus and treatment of the tumor per se. So depending upon the histopathology, like I said, like I explained to you what a ETV is. So majority of these tumors, they do present with obstructive hydrocephalus, where the goal of the procedure is two things: CSF decompression and obtain a histopathological diagnosis. So ETV, it becomes the optimal strategy in those cases. And the long-term failure rates in ETV is similar to the shunt, about 20 to 40%. And the reason for that is, when I said that you have to perforate through the floor of the third ventricle, which basically has two different membranes, and one of them is a tough membrane. It might the way we do it is with the help of a balloon. So it's pretty interesting, and sometimes you may get adhesions, and the membrane might reform. That's the cause of the failure most of the times. And ETV is a really cool procedure. It can actually avoid a lot of infection per se. And but the problem with the procedure is, depending upon the tumor, you can have like CSF seeding into the, because you are opening into the prepontine cistern. So even though the at that particular period of time, if the there's no CSF spread, you might induce one. So that's the problem with the ETVs. Stereotactic biopsies, like I said, it depends on the stereotaxis. Basically depends on the Cartesian system, and the way we do it is we get MRI, a stereotactic MRI, and based on that we decide the three different coordinates, the depth in X, Y, and Z axis, and that's how we decide our trajectory and do a rundown from our proposed trajectory just to avoid any important clinical important structures, so that you don't induce any hemorrhage in the brain. And it is preferable in patients with multiple lesions, patients who cannot undergo definitive surgery. The diagnostic yield as compared to an endoscopic biopsy is higher. It's about 87 to 97%. But similar to the endoscopic biopsies, because we are going through the cortex in both of these procedures, so there is chance of hemorrhage. So it is really important to review your trajectory in both of these procedures. And also it is important that you have to take multiple biopsies of the gland from different places because of the heterogeneity which can be there. Like I said, there can be multiple grades of tumor in the gland at the same time. So you have to take different biopsies from different locations. So the role of surgery here, apart from the treatment of hydrocephalus, it is considered as a gold standard, and but it's not easy. I will show you another presentation. There is a reason for that, why I say that. It's not an easy approach to pineal gland. And there are basically three roles of surgery in pineal gland. Let's go to the third one first. Like I said, second look surgery if the tumor is not responding to radiation. If you think it was, if your tumor workup suggested of a germinoma and you advise the patient to undergo chemoradiation, and then the patient came back to you with a follow-up scan showing a significant amount of residual, that's when you think about going for a second look. So that's one role of surgery. Second role of surgery is cytoreduction. So when you know you have already done a biopsy and you know that it is a significant size of tumor, which is not going to go away with the chemoradiation, that's when you do cytoreduction. So that's going to take away most of these cells and going to help in chemoradiation. So that's the second role. The third role is when you know your biopsy has suggested that it is a benign tumor and you can completely excise it. It's not going to go away with radiation, but there are still features of mass effects just because of the anatomical location. That's when you would want to excise the lesion. And because you know in a benign lesion, if you remove it for good. It's not going to come back. So that's the third role. The surgical approaches, there are various surgical approaches to the pineal gland. And important thing to consider here are, let me show you another one before that. Sorry about that. So this is the reason I said that the role of, we have to justify our role of surgery when attempting to operate on a pineal gland. He is Dr. Harvey Cushing, who is considered the father of modern neurosurgery. And this was his quote, that he never succeeded in exposing pineal region tumors sufficiently well to even justify an attempt to remove it. But obviously, with the advancement in neurosurgery, the surgical procedures have become more safe. And over the time, we are even able to do through endoscopic keyhole approaches now. But even then, I would say that you have to justify your attempt when you are planning to go for a pineal gland surgery. And let's come back to the anatomy. So this is the sagittal sinus here. This photograph is basically showing you the deep venous structures of the brain. This is the the inferior sagittal sinus, and here is going to be the internal cerebral veins, and this is the superior petrosal sinus, the straight sinus. You're going to see the great vein of Galen. So basically, your pineal gland is seated right there. So you have to be careful when attempting to approach the pineal gland. Important things to consider apart from the vessels is also the tent. This is the tentorium cerebelli, which forms the roof. It converges like this. It is an incomplete structure. It forms a roof of the posterior fossa, and the cerebellum is going to be here, and the occipital lobe, it rests on each side, and then you have the falx cerebelli here. So two cerebral hemispheres, the falx cerebri in the middle, and the floor is the floor of the occipital lobes is going to be formed by the tent. So the way the tent is oriented, that also helps to determine which surgical approach you're going to choose. I'm going to show you that. So this is the way we position the patient. That's a Mayfield head holder. And there are basically two approaches. Let me show you that. So this is a pineal gland lesion here. So the way you can approach, the blue one shows you the what we call as the occipito-transtentorial approach. Occipito for the occipital lobe, transtentorial because we need to cut away part of the tent to reach the pineal gland. So it's called as occipito-transtentorial approach. Obviously, we are coming from above the tent here. So these two, and the second approach, which is marked by the green triangle here, shows you the supracerebellar infratentorial approach, or SCIT. We call it the SCIT. And it was devised by Krause. It is known as Krause's approach. And the OTT, or the occipito-transtentorial, is known as the Poppins approach. So the Poppins approach is supracerebellar above the tent, and the Krause's approach is supracerebellar and below the tent. So these are the two important things to remember here. So this is another view from behind. This is going to be your operative view when we try to attempt OTT, occipito-transtentorial approach. Your superior sagittal sinus, the torcula, the straight sinus, and the transverse sinus, they gonna be on your left side if you're coming from the right side, and you're gonna see the falx cerebri on the medial aspect, and tent is gonna be on the floor of your surgical approach. So you have, but the way we approach these is, let me show you. Not here. So we basically, this is a short video. So we basically, these are the retractors. We need to retract away the occipital lobe to expose that area. And this is the tent is being visualized. Let's come back to it again. Give me a second. So how to choose between these two approaches. Your tumor is going to dictate as to what approach you have to, what approach is going to be good in a particular patient. Like in this tumor, which is really large, we have to see if the tumor is in the midline or it's extending more towards one side. Like in this one, it is extending more towards the right side. And in this one, it is more in the midline. So when we are coming from this approach, if we are coming from the right side, let me show you here. So this is the approach here. This is what you're gonna see on the right side. So if you're coming from the right OTT, it will be easier for you to see on the left side. It will be easier for you to see this extension, okay? So it will be easier for me to see the right extension if I come from here, or if, in other words, if a tumor is eccentrically placed, I would have a better angle of surgical attack if I go from OTT. And if the tumor is in midline, that's when I choose the SCIT approach, because I would be easily able to approach in the midline. Another thing which is important here to consider is the orientation of the tent itself. So the tent is slanted like this at the back of your neck. So your surgical trajectory is going to be looking at the roof. Sometimes we operate these patients in sitting position. So if we have the tent which is too high slanted, it becomes really difficult. While in few patients, it may be slightly horizontal, and it might be slightly easier for us. So these factors have to be considered when we are deciding about the surgical approaches. Let's go back to this slide. So these photographs on your right side, they show you the points which I just mentioned. And this is the another anatomic diagram where you can see all of these structures, what we encounter in the quadrigeminal space. So these are the colliculi or the quadrigeminal bodies, and this is the pineal gland. So all of these structures, they kind of converge in there. So we have to, it's a really narrow space, and we have to be really careful when attempting these approaches. Like I said, it can be performed in sitting position, and that's another important thing to consider while planning for a SCIT, because a sitting position puts you at risk, puts the patient at risk of air embolisms as well. So, and also it becomes difficult to manage by the anesthesiologists as well. So these are important considerations when we are planning for surgeries in these tumors. Different types of incisions have been described, but the classical one had been in a sitting position, midline surgical excision, midline surgical incision, and we do a small craniotomy to basically access that region. The one seen on the left side is by Dr. D'Amico. Basically, the place where he trained is they do a lot of these tumors, and they did a small modification, which is known as the lateral SCIT approach. It basically helps you, it provides a more relatively avascular plane, and it becomes slightly easier as compared to the midline approach. So that's why this patient has a incision marked on one side rather than the midline. And these, I'm showing you basically the steps of the surgical procedure here. We make 2 burr holes using the drill, And we have to identify, we have to be really careful because the torcula is going to be right there. And um, you have to be really careful when you're drilling. The patient might even die if the drill goes in. So one has to be really careful while performing this craniotomy. What you can see here, all you need is a small circular shaped craniotomy, and that's the dura. And after opening the dura, this is the superior aspect. That it's opened in a U-shaped fashion. The cerebellum is exposed here, and this is the tent, what you can see here. And I guess I don't have that video, I'm sorry. So basically the approach goes through the, when you retract the cerebellum down in a SCIT approach, you get to see these structures. You enter into the quadrigeminal cistern. You see the internal occipital veins and the basal vein of Rosenthal, the internal cerebral vein, and the pineal gland. So one has to be really careful when we are in the quadrigeminal space. And small modifications of this approach have been described, like in a pre-galenic approach or a post-galenic approach. Basically, it is the tumor which is going to dictate as to which approach we have to choose. And it becomes really important to get a MRV, that's a MR venogram in these patients to sort of orient ourselves even before attempting the surgery, to know as to what we're going to land into and what side of approach we have to choose. Another important thing which I forgot to mention in the OTT is this. So as we know, the occipital lobe, it helps in our visual pathway as well. So your retraction itself, the patient might end up getting a contralateral homonymous hemianopsia. So when taking a consent, we have to tell them that they might have this. And obviously, if the patient already has that, if the patient already has a contralateral homonymous hemianopsia, then that sort of gives you a surgical advantage that you can go from that side, because your retraction, you're not going to land up in any trouble because of this symptom. Let's come back to this. Occipitotranstentorial approach, I already explained to you. This is the position, how we operate in occipitotranstentorial approach, like I showed to you before. And these are the operative views of the quadrigeminal cistern. This, I guess, was looks like a epidermoid cyst there because of the pearly white appearance. So that's pretty much it from my side. Any questions?
I just opened the chat up, so if you want to stop screen sharing and take a look at the chat real quick.
Sure. All right. Do patients ever notice changes in their sleep patterns with pineal gland tumor or cysts? Well, they may. That's really interesting. So they may, but trust me, most of the time they say it is the pain which brings the patient to a doctor. They are really not bothered about their sleep. So if somebody has a headache or features of raised intracranial pressure, they are not going to care about their sleep. So I think it is hard to tell. I don't think anybody would have really studied that, but that's a potential area of interest that to notice the changes in the sleep pattern, because that's possible. Would a posterior interhemispheric approach while performing a colostomy be a good approach? Well, colostomy in itself is a really different procedure. And yes, definitely the posterior interhemispheric approach, um, it leads you to the pericallosal cistern, and we can perform a posterior colostomy through that approach, not the anterior one, obviously. So, but we usually avoid that because the superior sagittal sinus, which drains most of the excuse me, which drains the blood from major part of the brain. So we tend to have bridging veins more posteriorly. The superior sagittal sinus is more dominant posteriorly. So that's why we try to avoid posterior interhemispheric approaches. What's the significance of position during surgery again? I guess we already discussed that. So basically, when you are attempting OTT, you have to sort of put the patient in ipsilateral side down. So that's the reason for that. By ipsilateral side down is mean if I'm operating on the right side, I'm putting the patient with three-quarter prone position on the right side down, because that's going to help, because I'm going to need occipital lobe retraction, as I showed to you before. So if I'm keeping the right side down, it is going to fall because of gravity itself. I'm not going to need additional retraction. So that's where the importance of position comes. So in OTT, ipsilateral side down. In SCIT approach, sitting position, and with slight neck flexion, head holder is really important in both of these approaches. And that's basically a summary of these. Are melatonin levels affected due to the lesions? Yes, they can be, but we usually do not study those because the patient never complain of, I mean, I personally have never come across patient who presents with like a Pineal syndrome. They never mentioned to me that their sleep cycle is also disturbed. But yes, that can be done. The melatonin levels, they may get affected because of the lesions of pituitary. What was the thing in black and white you showed? There are a lot of things which I showed in black and white. I'm not sure which one you're talking about. If you're showing, how do the patients stay in place during the occipitotranstentorial approach? Let me show you the picture again. Like I said, we use the patient is basically, so we lay the patient supine, then turn them in a three-quarter prone position. We use pillows and support for the shoulders and for the chest. And the head, we basically bring out the head out of the table, and it's basically we use a Mayfield head holder or a Sugita head holder. So we basically use these head holders to keep them in position. Would you ever need to use a telovelar approach? Telovelar is basically, I would say no. Telovelar space is way down. Telovelar space is, we use those approaches towards the fourth ventricle. Let me show you the uh, presentation once again. SCIT approach is, how do I share? I'm sorry. All right. Okay. So for a SCIT approach, we basically go above the cerebellum. It's supracerebellar. So it's supracerebellar, and telovelar is, it's below, it's way down. It's not the same thing. Telovelar is below, it's the lower aspect of the cerebellum. And to the person who asked, how do we position the patient? That's how we position the patients. This is a Mayfield head holder. That's how patient is placed on the table with the shoulder roll in, and that's how we position. Why is midline more vascular than the lateral? Because we have the superior, the straight sinus right there. So you get to see all those veins, but definitely when we come from the, obviously it's less vascular as compared to the OTT. And you want to basically avoid the major sinuses in your approach. So that's the reason that we take these natural planes. ETV complications, we already discussed that because we are going through the cortex, then into the ventricle, the lateral ventricle, then into the foramen of Monroe, then into the third ventricle, and then we are opening up the floor of the third ventricle. So starting from the cortex, you can induce a hematoma. You can injure, like last time we discussed, the fornix forms a boundary of the foramen of Monroe. So you can induce fornicial injuries when you're going through the foramen of Monroe. When in the third ventricle, you can cause some bleeding because internal cerebral veins are there. And when you open up the floor of the third ventricle into the prepontine space, you have the basilar artery, which is really important. So when we open, we never use the electrocautery because you can literally injure the basilar artery and the patient might die right on the table itself. What are the risks associated with the surgical approach? That depends on the approach itself. I guess we discussed about that. Hematoma, injury to the vascular sinuses, air embolism, or because the position itself is so intricate that you have to sort of protect the pressure points so that you don't induce a brachial plexus injury, because it's kind of a weird position for somebody to position into that, but you have to be really careful while doing those. And obviously, you can injure all of these structures, the thalami on the either side, retraction injury because of the occipital lobe, injury to the cerebellum. So it basically depends upon the approach which we are choosing. May a pineal surgery ever require a patient to be awake during the procedure? Why would we want that? We don't really want that because it is a deep structure and you don't want patient moving. You're not going to gain anything if the patient is awake, because obviously you cannot, we are not monitoring for anything there. And awake approaches are usually used for either speech or motor and sensory monitoring, like tumors of the insula or left temporal lobe or of the left premotor or motor region. Does it impact mental illnesses? I'm not sure what you mean by that. What is the main reason for avoiding an open pineal surgery? For all of these reasons, that the one reason main is because majority of the tumors in the pineal gland, they are germinomas, and you can completely avoid a surgery. So why would you want your head to open up? No. So if somebody is presenting with a tumor, and the first question the patient is going to ask, am I going to need a surgery? If you know that it is germinoma, you can completely trust me, that would be you can give them the happiest day of their lives, that if you can avoid a surgery. So obviously, if you can avoid a surgery, that's the best thing. But there are these roles which we already discussed, that in a mixed pathology tumor, if it is not going away with chemoradiation, you have to do a second look surgery. If the patient presents acute with features of raised ICP, you have to decompress, and you might need a biopsy, or if it is a malignant tumor, you need to do cytoreduction. Those are the roles of surgery. How often can germ cell markers be used to forego surgery? Are they present often? We discussed about this about 80 to 90% of the time. The yield is about 80 to 90% in the serum and the CSF. That basically depends upon the assay, which we are using, the kit. And it's more of a rule in test rather than rule out test. So if you see, then you know that it is a germinoma, and that's when you can, give them chemoradiation. But if you don't see, that doesn't rule out. So it's a rule in test. What are the risks of pineal tumors staying in the brain and not being diagnosed? Obviously, because of the anatomical location, the patient may get all of those symptoms, which we already discussed. It may affect it may affect the vision, it may affect the sleep cycle, and obstructive hydrocephalus. Complications of surgery already discussed.
Hey, Dr. Khatri.
Yes, hi.
We're at 11 o'clock almost now, so we're going to cut you
Perfect.
off here. But thank you so
All
much
right.
for filling in such a
Of
short notice.
course. Thank you for giving me this opportunity. I love it. It's really great.
Thank you. Have a great day.
You too. Bye-bye.